we thought about this key. Let's start some series where it attributes not only to physical and diagnostic conditions of the patient, but also regarding mental health. Nowadays, people are aware of so much about mental wellness, so that they wanted to have some sort of counseling sessions by the different experts. So we also thought, okay, let's start some webinar series which can help all the other colleagues and doctors to have something about various diseases where mental health can play an important part. Recurrent pregnancy loss is such one of the topic where a single loss also can create a lot of negative vibes, not only in the mind of a woman, but also for the couple and the whole family. And let's believe this key today still most of the population resides in tier 2, tier 3 and the villages where a childless woman also considers as a social taboo or something like that. So before going ahead, I would like to introduce something about Medal Healthcare Limited, which has started the series. Let me share something about the company. So Medal Healthcare Private Limited is considered still as number one in radiological and pathological integrated system. So it's not only about pathology or radiology. We still find Medal is South India's largest integrated diagnostic person, where the services consist of both pathology and revenue with almost like 40 to 60% above. In addition to that, there are almost like 1 crore customers which are touched on an annual basis with the help of certain doctors and corporate tie-ups and other services. So mostly the pathological service consists of starting from routine CBC and urine analysis to till the higher and specialized and super specialized tests, including molecular biology and genetic testing. And not only that, in radiology also, Medal provides routine testing from starting from ECG and X-ray to CT, MRI, color Dopplers, or all those things. In addition to that, because of this integration of diagnosis, Medal provides a lot of wellness packages, so the patient don't need to go anywhere else. So over a period of time, Medal understood that not only this is required, it also need to put something in mental awareness where we can provide certain patients the benefit of mental health counselings and mind consultation. So that's how this mind consultation or Medal Mind has been created. So this is a service network. You can see mostly typical 4 South Indian states of Karnataka, Andhra Pradesh, Tamil Nadu, and Kerala full of Medal. So Medal has almost like 22 enable accredited lab, but also it also has a centralized QA system which manages the quality of enable and non-enable accredited lab to standards of enables. So it's almost like 1 crore patients or customers usually are being touched with the help of this approximately 8,000 customer points, 45 to 50,000 doctors, and 700 near about 700 corporate types. And I also had some PPP tie-up with the governments in Andhra Pradesh and Jharkhand, and tie-up with the government in Karnataka state also. Various awards in over a year, so latest being Best Medical Diagnostic Laboratory. And during COVID times, Medal was the largest private COVID testing facility in the South India. These are some of the highlights. After this, I would like to introduce, Dr. Anita Kant, who is the moderator for Dr. Anita Kant, who is the moderator for today's session. So Dr. Anita Kant is one of the highly appreciated and experienced gynecologists in India. She has started her career from Escort Heart Institute in Faridabad, which became later Fortis, and around 2010 she has shifted to Asian Institute of Management System Science, where she is working as a chairman of obstetrics and gynecology hospital. She has been associated with various organizations like Foxy, IMA, Menopause Society. In addition to this excellence in profession, she also is an avid writer, and she has written a lot of things around pregnancy, childbirth, which is related to parenting. She has many successful stories, but I think the latest one was successful child delivery by a 52-year-old woman, and that too triplets. So I welcome Dr. Anita. I would request Madam to take it ahead.
Thank you so much. Since Dr. Kamini Rao is stuck up somewhere and will be joining us a bit later, I would request you, Dr. Ramesh Kina, to give your presentation so that we don't waste time of our listeners.
Oh, sure, ma'am. Mm, let me share my presentation.
Yes, please. Basically, we are talking about recurrent pregnancy loss today, and it is a very valid point because a mother plans and plans and plans a pregnancy, a couple rather. They plan their pregnancy, okay, we'll have a childbirth in this month or maybe this year when we finished building a house or we finished taking care of our careers, we have reached where we want, and then they find it all goes boom. So once abortion is one thing, but if it happens more than one time, it is very disheartening. And that is what recurrent pregnancy loss is all about. Today we will be presenting where all we can help these couples in gaining their dream child, as we say, and giving them happiness and sharing their hopes with them, because losing a pregnancy is a very very painful thing. It's not only painful for the couple, for the whole family, even for the doctors who are treating them. And Medall have come up with certain packages where the tests can be done. We'll be talking to Dr. Rao about where and what tests need to be done, and what all needs to be explored, and what history to be taken, how to deal with these women and couple, both of them at one time. In the meantime, I'll request Dr. Ramesh Kina to talk about what packages in tests they are offering, because then they come out to be very cheaper, and in one go you have a whole panel of tests where okay, this is what is lacking and this is how we go ahead by treating this point. Over to Dr. Ramesh Kina.
Thank you, ma'am. I'll try to do my best in this. I hope everyone can see the PPT. Ritu, tell me if anything is missing or something like
Sir, slides are visible, sir.
Okay, thank you. Thanks a lot. Thanks, madam, about this opportunity. So today we are going to discuss about something about recurrent pregnancy loss. I know Dr. Kamini Rao is a stalwart in this, so I would wanted to have a touch up of few of the investigations, but let me start with this. So we wanted to understand what is recurrent pregnancy loss, what are the etiologies behind this, and what investigations to be done based on this today's webinar. So we understand not only physically, there is a lot of psychological effect because of any pregnancy loss. Now, and if it continues on, if it happens multiple times, that creates a very negative impact for the family. We all know that in any given pregnancy, the reported risk is still 15%. But when that happens, the chances becomes more and more in the next. So by definition, as per the European society and American society, it consists of 2 or more consecutive or spontaneous pregnancy loss. Now, if the woman has earlier live birth successful, it's called as secondary RPL. And if there was no live birth continuous, every pregnancy has been lost, it's called as primary. So this usually affects 1 to 2% of women in reproductive age. It can sometimes pregnancy also classified losses as occult loss and early before 12 weeks and late after 12 weeks. Now there are certain risk factors which increases the risk of this loss. First and most important is maternal age. So ideally we consider as 25 to 35 years of a female which is having a very good chance of having a live birth and all this. As the age increases, the risk increases. In fact, now it's become routine for all the gynecologists to have a double marker and triple marker during the evaluation of ANC to understand maternal age risk also. Second risk factor would be any previous miscarriages. Now, if anything happens, the consequence or subsequent to and loss can be on the higher side, sometimes 40%. Now, the third is during the modern era, there are so much of lifestyle changes, including smoking, whether it's an active, passive, alcohol, and the way we are living, there is full chances of high prevalence of obesity. These are also the risk factors of recurrent losses. Clinically, I would let it Dr. Kamini to handle. There are certain now over a period of so many years, so many studies has been done. So still we are able to classify some of the losses based on the etiological causes. So based on this and on the investigations which can be provided, there can be genetic causes either in the parents or in the fetus. We will come to that. Most important causes are autoimmune causes because they can be easily treatable. Then there are certain endocrine factors which are also studied whether they are increasing the risk or not. And infectious like torch, mycoplasmas. We have also come across during recent years about the thrombophilic disorders, which actually leads to venous thromboembolisms. So now there is a what you call full awareness of thrombophilic disorders like inherited or acquired. Then due to our lifestyle, environmental causes also can happen. Now 10 to 15 cases also are due to anatomic malformations like uterine malformations, cervical incompetencies, fibroids. People are still studying about the male factors because it's not only women which may have causes, there are certain male factors. But the biggest dilemma or biggest setback for medical society is that still there are causes which are unexplained. Almost like half of the causes which still not there. So we call it as idiopathic. So we talk mostly about genetic causes and autoimmune causes because most of the early losses are due to chromosomal defects, while immunological causes are mostly towards the late losses. But immunological causes can also be there in the early losses. Autoimmune disorders. We know there is an association of SLE along with the losses in second trimester. But most importantly, we would like to have, or there is a awareness about Anti-Phospholipid Syndrome. Why? Because still Anti-Phospholipid Antibody Syndrome is considered as the most treatable cause. Means patient can be given on anti or warfarin or heparins or all this. Now, this Anti-Phospholipid Antibody Syndrome is a different chapter altogether. But these all antiphospholipid antibodies, what is more important is they consist of antiphospholipid antibodies. We'll come to that. So antiphospholipid is again primary if it is not associated with any other disorder, and secondary if it is associated with certain SLEs or drugs. Rare cases can have catastrophic where there is a high incidence of generalized thrombosis and mortality. So what are these antiphospholipid antibodies? So there are three types of antibodies, but they are actually not acting on phospholipids. They are acting on phospholipid binding proteins. So most prominent of antibodies is IgG, but IgM and IgA is also there. The dilemma comes because it is also seen in 5 to 15% of normal population. These are the just pathogenic mechanism where they can either induce fibrinolysis inhibition, but in RPL they can also do a reduction of proliferation in trophoblastic cells. So these are the three important, most common important antibodies of antiphospholipid syndrome. Lupus anticoagulant. Maybe 5 years back we were doing like once a week test. Now it's a very routine test because many patients come for that. Second is anticardiolipin and anti-beta-2 glycoprotein antibodies. Both can be done by ELISA and done on serum, while lupus anticoagulant is done on plasma. So there are other antibodies like phosphatidylserine, inositol, and choline. Out of all these antibodies, still lupus anticoagulant antibody test is considered the strongest indicator for adverse reactions. And there are many types of tests for identifying lupus anticoagulant, like a prolonged APTT. This really. There's something about DRVVT, which we do in a routine laboratory. So it's actually in vitro ability to induce thrombosis. It's not an easy test. It consists of three parts. First, we do a screening test where the clotting time is measured If it is on the higher side, then we do a confirmation test by adding more and more phospholipid rich DRVV reagent. And there is also mixing studies. Then there is a calculation of a normalized ratio by calculation of screening and confirmation. So if this normalized ratio is more than 1.2, we consider as LA detected. Why mixing studies is important in this case also? Because there can be some factor deficiencies or inhibitors which can alter the results. So mixing studies help us to understand whether their particular factor is deficient or inhibitors, or it's really LA present. This is just principle of DRVV test, where we do a screening test in which clotting time becomes prolonged. And when it is corrected by confirmatory reagent, then we call it as LA is present. Still, diagnosis of this is challenge because titers are very fluctuating. Different laboratories will have different standardization. Different instruments will also have different standardizations. And most important in all these tests are pre-analytical variables, because these tests are heavily dependent on separation of plasma from the sample, then storage and transport temperature of the sample, which can alter the result. Still, one clinical and one laboratory criteria is used to identify for APLA. I would let clinical criteria for Madam. For laboratory criteria, again, there are 3 types of antibodies. Lupus anticoagulant is more specific, but anticardiolipin antibody is more sensitive. But to diagnose, we call it, to diagnose it as a positive test, either of these 3 tests should come positive 12 weeks apart. And not only that, in cases of antibodies like anticardiolipin or anti-beta-2 glycoprotein, their test result should be on the medium or higher side. It's not just in the above normal range. Now let's come to genetic factors. Genetic factors can be both from the parents or from the fetus. So in parents, usually it's found as structural chromosome abnormality like Robertsonian translocation. And in embryo, it can be monosomy or trisomy. So genetic test can be done currently by 2 types, karyotyping by G banding or FISH. Now the basic difference is karyotyping by G banding, which is routinely used by culture method. Almost all chromosomes can be identified, but only up to 20 cells can be screened, and it has a limitation of high amount of maternal contamination, which can give erroneous results. The advantage of FISH is that it can identify mosaicism, and the whole chromosome can be identified with specific target DNA probes. But again, it does not include all the chromosomes. Now, the newer tests like array CGH, means comparative genomic hybridization, have also come, and most of the societies like European, American, RCOG is also recommending that we should start array CGH only for these type of tests. But again, it also has some limitations like maternal contamination, and it cannot identify individual mosaicism. This is just an example of how a karyotyping result looks like. You can see all the chromosomes. There's 3 and 7 balanced translocation. Now, as per the recommendation, ideally the product of consumption genetic testing is more important than parental testing. It's said that when the POC testing is abnormal, then we should also go for parental testing. So again, this left-hand side is FISH, and this is now karyotyping with normal G banding. Nowadays, prenatal diagnosis is also getting a lot of awareness. So prenatal diagnosis is also can be done by chorionic villus sampling or amniotic fluid or cord blood by karyotyping FISH or CGH. But there are some common indications like very advanced maternal age, maternal like dual marker is on the abnormal side with high risk, triple quadruple marker is also showing high risk, if there is suspected duplication syndrome or family history. Just a little bit of prenatal diagnosis, it can be done aneuploid screening by double marker, triple marker, or by genetic testing. In that also, if you say double marker and triple marker, I would say Based on the history, sonographic finding, and biochemical reaction of double marker always have a highest detection rate. That is approximately 90 to 95% as compared to triple or quadruple marker. Something about thrombophilic disorders. Now, this has get a lot of what you call awareness in people's and clinicians' mind, and every lab is doing almost all these things. So there are like inherited thrombophilic defects and some acquired thrombophilic defects. All contributes to venous thromboembolism and sometimes pulmonary embolisms, and RPL also is a cause. So in inherited thrombophilic defects, usually it's a factor 5 laden mutation or factor 2 like prothrombin gene mutation, or there is a deficiency of protein C and S. You see a little bit about this. So factor 5 laden mutation is why it's important, because if it's a homozygous mutation, then there is an 80-fold increase of thrombosis, which can definitely affect the fetus and everything. And it's a very high sensitive and specificity PCR based test. The only limitation is that it's still found in 2 to 5% of general population. And if the patient is on heparin therapy or they have a blood transfusion, then due to PCR interference, erroneous results can happen. In fact, same with prothrombin gene mutation, that is factor 2 mutation. Again, it's high sensitivity and specificity, but again, patient on heparin and blood transfusion can alter the results. So protein C and S deficiency is also present in almost 2% of general population. They are less common associated with RPLs or recurrent pregnancy loss, but when they are present, they have a strong association. So this is also done on plasma samples. Now, apart from this, let's come to some endocrine factors. Various studies has been done to find an increased risk of association for pregnancy loss with various disorders. So few of the conditions we can discuss. In that, hypothyroidism is one of the important cause, and that too subclinical hypothyroidism. Now there is general awareness if the TFT or thyroid function test is within normal limits, but if the TSH is more than 2.5, any clinician should think about subclinical hypothyroidism and treat accordingly. In addition to that, it's seen in RPL cases, patients usually have high level of anti-thyroid peroxidase antibody, anti-TPOs than anti-TGs. So that's also an independent marker for increased risk. Diabetes mellitus, if it is controlled, it's said no risk, further risk of miscarriages. But yes, if it is poorly controlled, then there is an increased risk. So this can be done by or can be identified by high blood glucose level and high HbA1c level in the first trimester only. And these women usually have high HOMA insulin resistance, so that will always be on the higher side. So these tests also can be understand to find insulin resistance. Polycystic ovarian disease also in some cases it has been identified as a risk factor. So because of excessive production of androgens. So there is panel of polycystic ovarian syndrome in most of the laboratories, and it also consists of increased testosterone, SHBG, and free androgen index. There are many studies which also find out luteal phase deficiency because of lower progesterone levels. So secretory endometrium doesn't get proper. But this diagnosis is difficult because you have to have very timely endometrial biopsy. So currently people are using progesterone, low progesterone levels to find out in 3 different samples and then addition of those. Hyperprolactinemia is also known as one of the, so if we have to go to suspect hyperprolactinemia, definitely prolactin needs to be done. Homocysteinemia, increased homocysteine also is considered as risk factor for thromboembolism, but in few of the studies. Many people have already studied for ANAs because it's most of the time it's autoimmune, so ANA has been studied, but not much significant association was found with these tests. Infections, usually, yes, nowadays infection or TORCH screening is almost a part of the antenatal screening because they are associated with recurrent abortion, IUGR, malformations. But not only TORCH, certain cases, certain organisms like Listeria, Mycoplasma are actually associated with the increases, but their role is very less clear. Now for these, there are different types of tests available like PCR, antibody screening like IgM, IgG. Important is avidity screening. Let's understand this word. So basically, for this TOR screening, presence of IgM antibody, or we forget normally, four-fold rise in IgG titers. It indicates a recent infection. Only IgG does not indicate any recent infection. But if there is a misunderstanding of the report or how to interpret this, we usually should do an IgG avidity test also. So if the avidity IgG is low, then it indicates recent infection. But if the avidity is on the higher side, then we can consider as past infection. The problem is that most of the infections are only subclinical. So sometimes it's become difficult to interpret. Male factors are also being studied along, and most of this is found due to excessive or very sedentary or unhealthy lifestyles. There can be sperm damage by oxidative stress. So there are tests which are available to understand the DNA fragmentation of sperm, like sperm chromatin dispersion analysis or structural assay or tunnel tests. So now 10 to 15% cases are due to anatomic factors. Most of the cases are due to congenital uterine malformations, most prominent like septate uterus. In addition to that, bicornate or eucornate uterus. There can be other conditions like fibroids, polyps, chronic endometritis, sometimes cervical incompetence. Now, it's known that for identifying all this ideally a transvaginal 3D ultrasonography or sonohysterography has very high sensitivity and specificity, and it should be performed. That's the problem. Still, approximately half of the patients, we still don't know what can be the causes. So these are the outline of basic investigations which are recommended for evaluation in current practices. Like for genetic causes, we can do genetic testing or karyotyping of parents or karyotyping of the product of conception. Immunological causes, definitely we should do cardiolipin and anti-cardiolipin antibodies, anti-beta 2 glycoproteins, lupus anticoagulants. Anatomic causes, we have, if we suspect, we have to go for sonohistography. Infectious causes, we can just find out by doing a TOR serology or some cultures from the cervical. In addition to that, our antenatal package also consists of endocrine factors like to see subclinical hypothyroidism or antithyroid antibodies, to find out whether the patient has diabetes or insulin resistance, high prolactin or LH going to PCOS. In addition to this, also now to evaluate thrombophilic disorders, we have to do protein CNS activity, factor 5 and factor 2 mutations. So this is a generalized picture. There is a guideline from Royal College, American Society, European Society. So recently in October 2020, Papa et al. Has proposed a new recommendation. In this, they also say ki, okay, the first for genetic testing, ideal is first we should do on a product of conception, and if it is found abnormal, then parental testing should also be done. For anatomical, definitely 3D ultrasound and sonohistography should be done. Anti-phospholipid antibodies are also recommended in all the studies, and you proposed also specifically for 3: anti-cardiolipin and lupus anticoagulant and beta 2 glycoprotein. Thyroid function also to find out or evaluate subclinical hypothyroidism, TSH is definitely required, and TPO is also being done. To find out hyperprolactinemia, prolactin is also recommended, and to find out diabetes mellitus, first trimester HbA1c is also recommended. Now, protein C, protein, these are new tests, but if we suspect a strong family history or personal history of, or there's a history of thrombosis, they should also do like protein C, protein S. And apart from this, other tests are not recommended, but yes, we can actually prescribe those tests based on the clinical judgment and history of the patients. Thank you. But I would like to share one more thing which most of the people forget is this. This is generalized list of those tests which we have discussed, where what is the methodology. Most important, because there are two tests here in lupus anticoagulant and protein CNS, which consist of plasma. and these need to be done in frozen plasma. So there are a lot of pre-analytical issues which clinicians should also know, and my laboratory colleagues should also understand and interpret in a manner. Okay, thank you all.
Thank you, Dr. Ramesh. You really put in a comprehensive of all the tests that need to be done by a clinician while investigating a patient of whether it's recurrent abortion or even a single abortion. You have beautifully consolidated the whole presentation. I would like to welcome Dr. Kamini Rao.
Thank you, Medol Diagnostics, for giving me this opportunity, and for IJCP for kindly hosting this program. And it is my pleasure to take on a difficult subject like recurrent pregnancy loss. I say difficult because we don't have a single answer to this problem clinically or biochemically or radiologically. And I think this is going to be an enigma at the start of my lecture, and I hope I can make this enigma less confusing and with more consensus at the end of my talk. But I would like to tell you that I don't have any magic solutions. But let's start at the very beginning and looking at what the definitions are. Eshrey says that more than 2 pregnancy losses, or even equal to 2 pregnancy losses, which includes biochemical pregnancies and pregnancies of unknown location. Pregnancy loss is used as a general term, and early pregnancy loss, the first trimester pregnancy loss and second trimester pregnancy loss when gestation-specific reference is needed. However, when we look at the RCOG, they just categorically say 3 or more consecutive, that's the word, consecutive, one after the other pregnancy losses. But the American College say something different. That is, 2 or more pregnancy losses confirmed by ultrasound or histology, not necessarily consecutive. So, if we have to look at the incidence here, recurrent, that means one after the other, repetitive, recurrent pregnancy loss occurs in 1 to 3% of all couples trying to conceive. The risk of pregnancy loss increases with each loss from even as much as 11% and can go in as far as nulligravida to as much as 40% after 3 consecutive pregnancy losses. That means almost 2 out of 5, and that's quite a lot. And that is after 3 pregnancy losses. But the prognosis worsens with the increasing maternal age. The incidence of recurrent pregnancy loss is higher among the infertile women. Now, this is something that one needs to understand. It's not only a physical component, but the psychological impact. It's mind over matter. If it doesn't matter, then it won't mind, but it does mind. And therefore, what is the psychological impact? Pregnancy loss is a significant negative life event, and such recurring events may intensify the grief experienced and a sense of personal failure. Childless couples and women may face discrimination, stigma, and ostracism. Therefore, appropriate support should be offered to reduce the associated psychological burden. Couples want the medical team to know their obstetric history and to provide compassionate care, show understanding, take them seriously, and show empathy. And clear information about the cause of miscarriage, the likelihood of recurrence, the tests required, and treatment that could prevent a recurrence. Therefore, studies have most focused on women, so there is a need for studies on the emotional impact of recurrence in pregnancy losses on men too. So, what could be the risk factors? The one important risk factors that we are not so familiar with are the genetic factors. The structural chromosomal anomalies are seen in approximately 2 to 5% of recurrent miscarriages. Most common, balanced reciprocal or Robertsonian translocations. Others include chromosomal inversions, insertions, and mosaicism. Low maternal age at second miscarriage, history of more than 3 miscarriages, history of more than 2 miscarriages in brothers and sisters, and history of more than 2 miscarriages in parents of either partner all increase the probability of a carrier status. But we can't forget the epidemiological factors or the thrombophilias. When we talk of epidemiological factors, we have to look at the advanced maternal age, and that would be above 35 years of age, and the number of previous miscarriages and advanced paternal age of more than 40 years. And looking at the lifestyle habits, such as maternal smoking, alcohol consumption of more than 5 units per week throughout pregnancy, or over 3 per week in the first trimester. Caffeine consumption, and that's coffee, 3 to 5 cups per day, and obesity, illicit drug use like cocaine. What about thrombophilias? Acquired thrombophilias, Antiphospholipid Syndrome, hyperhomocysteinemia, acquired protein C resistance, inherited thrombophilias, antithrombo 3, protein C deficiencies, protein S deficiency, and factor V Leiden, prothrombin gene mutation, common and weakly thrombogenic. What is antiphospholipid syndrome? It is almost accounting for a fifth of these thrombotic episodes. Yes, dear friends, yes, it is a fifth of cases. Most important, treatable cause of recurrent miscarriage. Recurrent fetal loss typically occurs in the second trimester and may occur at any stage of pregnancy. Only 10 to 15% of women are anti-phospholipid antibody positive. The probability of finding APL in prenatal exams is less than 2%. So, what can be an antiphospholipid syndrome diagnostic criteria? At least one clinical criterion, that is, either a previous thrombotic event or gestational morbidity, and at least one laboratory criterion confirmed positive APL at more than 2 separate time points with a 12-week minimum interval. On my right hand, you have a table which will suggest to you the international consensus classification criteria for the antiphospholipid syndrome, and that is the APS. This has been as recent as the fertility sterility of 2012. Now looking at more of the anatomical factors for the recurrent pregnancy loss are the uterine factors, and that could be in the form of abnormal uterine anatomy, in the form of congenital and malformations, septate uterus, Double uteri, arcuate uterus, acquired anomalies like fibromas, uterine polyps, intrauterine adhesions. Women with septate uteri are more likely to miscarry in the first trimester, while those with an arcuate uteri have more second trimester miscarriage. Cervical incompetents are more likely to have a second trimester miscarriage preceding a spontaneous rupture of membranes or a painless cervical dilatation. The lining of the uterus, which we call as an endometrium, gives an impairment in the endometrial quality and may affect implantation and placentation, impaired proper embryo development, miscarriage, and recurrent pregnancy loss. Chronic endometritis in 10 to 15% of the infertile women and 40% of endometrial cases. Looking at the hormonal and metabolic factors, hypothyroidism, antithyroid peroxidase antibodies, Hashimoto's thyroiditis are at-risk factors. Treated thyroid dysfunction is not a risk factor for recurrent miscarriage, but uncontrolled diabetes is a risk factor. Hyperprolactinemia may be associated with recurrent miscarriage, and that loss is because of the alterations in the hypothalamic pituitary ovarian axis and impaired folliculogenesis and oocyte maturation and or a short luteal phase. What about the infections? I'm sure you know there are infections in terms of bacterial infections, protozoal infections, viral infections, and whatnot. But that would account for almost 0.5 to 5%. Infections include Listeria monocytogenes, toxoplasmosis, rubella, herpes, measles, cytomegalovirus, coccidiovirus, mycoplasma, ureaplasma, chlamydia, and trachomatis. As most of these infections are isolated events, there is apparently limited role for infections as an etiological factor in recurrent pregnancy loss. Proposed mechanisms for infections causes of pregnancy loss include a direct infection of the uterus, fetus, or placenta, placental insufficiency, chronic endometritis or endocervicitis, amnionitis, infected intrauterine device. But so far, we have been talking only about the female factors. Please understand that it can also have male factors. Standard semen parameters, including sperm morphology, are not predictive of recurrent pregnancy loss. Abnormal DNA fragmentation, advanced paternal age, or exposure to correctable environmental factors such as exogenous heat, toxic exposures, varicocele, or increased reactive oxygen species in semen, or ROS as it is called. Unexplained recurrent pregnancy loss where no apparent causative factor is identified in over 3/4 of the couples. Chances of future successful pregnancy in such cases can exceed to over 50 to 60% depending on maternal age and parity. So when we actually look at the diagnostic evaluation, one has to understand, can we identify the underlying treatable condition to try to improve outcomes? History taking is important. Previous obstetric history of any preterm birth, gestational age, bleeding tendencies, have to be emphasized and has to be recorded. Physical examination, general physical assessment, including examination for signs of endocrinopathy, is extremely important. So also pelvic organ abnormalities, uterine malformations, and cervical lacerations. In all this humdrum, we always forget the mind of that particular couple. Always, always, as an integral part of a screening program, screen for depression. Because depression is the one thing that many of us fail to recognize. So, make sure that if she needs a counselor, this is the time for you to put them across to a counselor or a psychiatrist. What about the antiphospholipid antibodies? Of course, you need to do that. The indications would be 3 or more unexplained spontaneous abortions before the 10th week of gestation, after excluding maternal, anatomic, or hormonal abnormalities and paternal and maternal chromosomal causes. Single unexplained loss of a morphologically normal fetus at more than 10 weeks gestation. 2 positive tests at least 12 weeks apart of either lupus anticoagulant or an ACL, IgG or IgM in moderate to high titers, that is more than 40 G per liter, confirms the diagnosis. Screen for inherited thrombophilias like factor V Leiden and prothrombin gene mutations, protein C, protein S thrombin deficiencies. If personal history of venous thromboembolism due to non-recurrent risk factors, example surgery, or a first-degree relative with a known suspected high-risk thrombophilia, women with any unexplained stillbirth and more than a second trimester loss, uterine factors, then hysteroscopy, laparoscopy, MRI, and a 3D ultrasound, transvaginal or transabdominal ultrasound, sonohysteroscopy, and hysterosalpingography may be warranted. Abnormal chromosomes, while chromosomal analysis of both father and mother is mandatory. Abnormal embryonic karyotype, chromosome analysis of the products of conception, and endocrine abnormalities requires testing for diabetes, thyroid functions, and prolactin, metabolic syndrome, PCOS, as suggested by the history and physical examination. The torch screening, however, has been very controversial, and perhaps in the 90s and late 80s, it had been very rampant to test all these people for torch. However, now, unless there is anything specific to test, I don't think that torch infection has any role at this point of time to test. And when it is tested, it has to be very specific in cases of toxoplasmosis, because most of the women girls are being given vaccination for rubella, and so they are always vaccinated for rubella, so it's unlikely that they'll have it. And most of the ones that have herpes are not likely to respond with the early miscarriages. Infections caused by torch agents in women are usually asymptomatic and chronic. Torch infections are associated with recurrent abortions, IUGR, IUD, preterm labor, early neonatal death, and congenital malformations. However, previous history of pregnancy wastages and positive serological tests during the current pregnancy helps to reduce adverse fetal outcome. However, even with a positive IgG test, it still does not confirm that the woman has an active infection in this pregnancy. So, if we have antibodies of IgM and IgG against toxoplasmosis, rubella, cytomegalovirus, herpes simplex 1 and 2, we need to look at it much more closely. Absence of antibodies indicates a negative result, while presence of antibodies indicates a positive result. A negative result for both IgG and IgM indicates no previous or recent infection. The positive result for IgM and negative result for IgG indicates a recent infection. A positive result for IgG and a negative result for IgM indicates an old infection which may have occurred already or a vaccination. So, if we have to look at the suggested diagnostic evaluation of recurrent pregnancy loss based on etiology, let's look at the summary of the chart on the right hand side. If you look at the genetic thing, you look at the parental karyotype. If it's anatomic, then you look at the HSG, an office hysteroscopy. And if you look at the endocrine, you look at the thyroid, the prolactin, the insulin resistance, and perhaps the antithyroid antibodies. If it's infections, no evaluation recommended unless patient has evidence of a chronic endometritis, cervicitis on examination or is immunocompromised. Autoimmune anticardiolipid antibody levels IgG, IgM, lupus anticoagulant. Non-APS thrombophilias, homocysteine factor 5 laden, prothrombin promoter mutations, and activated protein C resistance. So, you have a very busy slide here, which is the evaluation of recurrent pregnancy loss, which has been agreed by the RCOG, ASRM, and the HRA recommendations. And if you put them all together here, the HRA has the recent recommendations here, which really tells you a summary what I have spoken to here to you all along. But it only gives you that summary. Finally, it has to be individualized to each individual case. Nothing can be painted with the same brush. We have to take the patient as a whole. You can't take it to be an organ-specific thing. We have to be very clear that when we are taking all these things, do not forget that beyond all this, stress can be a very important factor. You may find nothing wrong with the patient. It could only be a stress factor that has not allowed her to go through the complete pregnancy. And even after leaving all of you, she can still go and have an absolutely normal pregnancy. And believe me, you could have done the maximum number of tests and she would still not have continued the pregnancy. But the moment she has left your clinic and she's gone away from the stressful situation at home and in your clinic, she will go ahead and have an absolutely normal pregnancy and a normal delivery. And I have seen many such cases happening. So the treatment here would be counseling of the couple, investigations and the outcome of investigations, treatment plan and outcome of treatment. Psychological support before, during and after is absolutely important. Give strong psychological support to the couple. Genetic counseling, couples with abnormal karyotype detected during the screening period should be referred to a clinical geneticist where available for detailed counseling about outcome of future pregnancies. Lifestyle modifications including weight reduction, exercise, cessation of smoking, limiting alcohol consumption cannot be overemphasized. So, if you looked at this again is a busy slide, but again is a summary of what I have been telling you on all my previous slides. So, the therapeutic interventions for recurrent pregnancy loss based on etiology is all put on this slide for you to see. So, this is again a continuation In the treatment of recurrent pregnancy loss, comparison of all the guidelines that you have from the HRA, from the ASRM, and the RCOG, and all other guidelines. So you have specific treatments for a few of the problems, but you don't have treatment for a lot more problems that you may think that you have cracked the Da Vinci Code. But my dear friends, we still have to learn much more, and that is empathy, compassion, and counseling. That needs to be understood, that a lot of empathy and concern has to be given to the woman. It's not easy for a woman to face an abortion. It's not easy for a woman to face that loss. So please understand, it's not so much of a physical problem. It's more of a counseling that needs to be done in this case. And we have to all help this woman to get her status back in society. She should not feel incomplete. She should feel complete. She should feel the complete woman that she is. And just because she has this abortion, she should not feel that she is less of a woman. And when you make her feel that complete, there's a lot of neurotransmitters in the brain that sort of, equalizes within itself, which no medicine can do. And I'm sure the doctor has that power, that everything cannot be cured by medicine. So, tender loving care, TLC. That's not put on my slides. But believe me, that's the strongest medicine that you can give to the patients. Whatever number of tabular columns I can put over here. But that's the biggest tabular column that I can give you throughout my slides. If I tell you that you can do it and this can happen, many of these people will be able to conceive without any of these supports, particularly the unexplained recurrent pregnancy loss. So treatment of recurrent pregnancy loss where there is no cause will really be supported by counseling, and more counseling. So the overall prognosis is going to be good. Individual prognosis depends on the underlying cause and the number of prior losses. Correction of endocrine disorders, anti-phospholipid antibodies, and anatomic anomalies have the highest success rates. Success rates in patients with cytogenetic basis for the loss is 20 to 80% depending on the type of abnormality present. So therefore, prognosis depends on the origin of the problem. So evaluate the couple after more than 2 pregnancy losses to determine the cause of repeated miscarriages. Refer to reproductive specialists. Etiologies include antiphospholipid antibody syndrome, uterine anomaly abnormalities, hypothyroidism, uncontrolled diabetes mellitus, parental chromosomal abnormalities. 50% of recurrent pregnancy loss remains unexplained, and that's where the tender loving care comes in. Diagnostic evaluation includes assessment of uterine anatomy and, of course, anti-thyroid antibodies and the protein C and S and the anti-phospholipid antibodies, factor V prothrombin gene mutations, and I am not really convinced about the torch infections. Antenatal counseling and psychological support. Treatment is directed towards etiology, and prognosis depends on the etiology. So, in my final slide, I would like to tell you that if you are able to look at the patient as a whole, as a mind and body, and not look at her as a uterus and a pair of ovaries, I think I would have been successful in convincing you people that my lecture today on recurrent pregnancy loss was extremely worth it. Thank you very much.
And most of them have been answered during the talks presented, Dr. Kamini's talk and Dr. Ramesh's talk also. But there is one question which I would like to be answered. Is there any association of stress with recurrent pregnancy loss? Work related stress or job or home related stress for a woman which can lead to recurrent pregnancy loss? Can you answer?
Can I talk?
Yes, ma'am, we can hear you.
Okay. Well, the question was stress, and
Yes.
I fully agree with you that how do you define stress? And there are very many parameters that have actually been laid out on how you grade it. But it depends on different individuals on how they handle stress. But nevertheless, the overarching factor that stress is a very important factor in recurrent pregnancy loss. So, if we were to look at a whole lot of literature, I'm sure you will have anecdotal experiences where women who have had 3 and 4 recurrent pregnancy losses, where they have left their original habitat and have moved out, be it the home, be it the city, be it an environment, and have settled somewhere else and have found themselves many a time away from that common environment. They've been able to have the pregnancy continue without any issues altogether. Perhaps it is the endorphins or the steroid production, or it is a question of the chemical neurotransmitters that actually get altered in the system itself that allows for the pregnancy to continue. When we say 50% of these recurrent pregnancy losses for which there is no answer, well, stress comes into that category of recurrent pregnancy losses, where very, very quickly, when they actually change that environment and the stress factor, you find that results occur.
Thank you, ma'am. That was very nicely said. Almost all the questions have been answered by your presentation, ma'am. But there's another question. Is IVF with pre-implantation genetic screening helpful in unexplained recurrent pregnancy loss?
Yes. If IVF is the answer for unexplained recurrent pregnancy loss, is that the question?
No. Is it the answer for, yes, unexplained recurrent pregnancy loss? And PIGD screening they are talking about.
No. No. If IVF is done, it should be followed with some kind of PGT, or it should be followed also with, say, for example, ERA, because without that, just doing for an unexplained pregnancy loss, you have to explain something with IVF. Now, when a woman is already getting pregnant and implantation is occurring, there is no point in doing an IVF. However, if you are suspecting the quality of the embryo, then certainly selection of the embryo can be done in the IVF program using either the embryoscope or the PGT, and thereby selecting the embryo. So if you are suspecting any kind of an aneuploidy, or for example, aged oocytes, or for example, if there are certain problems in the endometrium that is not conducive for continuation of the pregnancy, and in such situations, perhaps an IVF will help. But IVF is not a panacea for unexplained recurrent pregnancy loss.
Yes, I agree with you, ma'am. Thank you so much for putting it so nicely across to all of us. Ma'am, there's another question. Are torch infections really responsible for recurrent pregnancy loss? Should they be done in today's world, for recurrent pregnancy loss, not for one loss, but for recurrent pregnancy loss? Should we do those tests?
See, first and foremost, I want to put it very clearly that maybe in the early 90s, late 80s, early 90s, we were doing extensive torch pregnancy tests. But when we actually looked at the infertile population, and we found that the cytomegalovirus population of an IgG was positive in almost 70% of women who were infertile, who did not have recurrent pregnancy loss and who were infertile. However, if you were to look at the pregnant women and who were not pregnant at the time when the testing was done, 50% of them had CMV virus positive. Now, the significance of this is that yes, they are positive, but how many of those CMV virus positive are actually going to affect the fetus? Now, if you look at the CMV virus and you are looking at the IgM antibodies, for example, IgG antibodies being positive is of no significance. And if IgM antibodies, one has to actually look at whether the IgM antibodies appeared for the first time or there is a rising titer. Even if you have an IgM positive, how much of that will actually cross the placental barrier? The only way you can find out whether the IgM antibody seen in the maternal blood is actually going to infect the fetus is by testing the fetal blood and finding out whether the cord blood has IgM antibodies, because the IgM antibodies of the maternal blood does not cross the placental barrier. So if you have tested the cord blood and you find that the IgM antibodies emanate from the cord blood, then there is an infection in the cord blood, then the baby has CMV virus positive. Now, if you look at every IgM positive, you will hardly have a 0.1% of pregnancies with an IgM positive who will have a fetal infection. So you must now look back and say, am I really going to test so many people to see that 0.1% of babies that are being infected? So, in fact, the Royal College as well as the American College have actually done away with testing for torch infections for recurrent pregnancy loss. And this has been, and once the person has had a torch positive and has been treated, question of getting it as repeated treatment is not warranted.
Thank you, Mom. You have actually put it across so well to all of us gynecologists that I think after this we will not make this mistake. There's another question that can on ultrasound, are there any signs suggestive of an impending pregnancy loss?
Well, signs of an impending pregnancy loss, again, it depends on the time of gestation. One is if it's a very early pregnancy loss, depends upon at what gestation. If it comes before the heartbeat, obviously, you know that most of them will be genetic defects and of aneuploidies. And if you're looking at something between the 6th to the 8th week of pregnancy, please have a look at where the gestational sac is, whether it is at the lower stage, and whether it is implanted low, and also the size of the gestation sac, whether it's irregular or not. You'll also have to see where exactly the position of the fetal heart is, the rate of that fetal heart. Sometimes if you get a good fetal heart rate of about 130 or so, it's fine. But when you see a feeling heart, almost like having a flicker and nothing beyond that, you know that within a short time that there's going to be a demise. Also, you would be able to see, has there been any kind of bleed around that gestation sac, and then you also know that there's a likelihood of that fetus, that gestation sac not continuing. And you may not always see corpus luteum in the ovary every time, but that also could be one of the reasons that not seeing a corpus luteum could only be a supportive evidence, but may not be the only evidence that the pregnancy is not going well. Also, if you look at the beta HCG values, you may not see that significant rise that you would expect. The doubling effect of the beta HCG may not be there compared to a healthy pregnancy. So these are some of the things that you will be able to see on ultrasound as well as the biochemical parameters.
Thank you, ma'am. Thank you for joining us amid so much of busy schedule of yours. I know you were busy somewhere, and I took over your presentation and shared it with people. It was a real good presentation, I must say. Thank you, ma'am.
You did a wonderful job. Thank you very much, and I'm very sorry about this.
No, I understand you must have been busy.
But I don't understand, but I'm very happy that I got a chance to talk to the viewers. Maybe sometime I would get a chance to repeat this at some other stage.
I think I'll tell Medall people to arrange another one with you, actually talking to the people. And I think Dr. Ramesh is smiling. He will do it. Thank you, Dr. Ramesh.
Yes.
Thank you, Medall. Thank you,
One point
Yes, please.
One point I wanted to add on this. Now, there are so many causes and so many tests involved. So you talked about some packages early in the day which is useful for the patient. So I wanted to emphasize, yes, there are packages, some lab called as thrombophilia, some called as thrombocheck, some called as BOS, some called as RPL packages. But yes, we also have like packages, package 1, package 2, package 3, based on the number of tests. Like in all these tests, lupus anticoagulants, cardiolipin antibodies are there along with protein C, protein S, and then the more you go, factor 5 latent mutation, factor 2. So there are packages available.
Antithrombin 3.
Yeah. Antithrombin 3.
All costly.
Yeah. So all those are available just for the benefit of the patients.
Yes, definitely. But yes, making packages by companies is really helping us because, while listing it down, you may miss out something. And if we can give some financial help to the patient, they'll really appreciate it. What does ma'am has to say about it, Dr. Kamini, please?
I do not believe in these packages because packages are created by these companies. I would like to look at the individuals and select what is the tests I would like to do.
Yes.
And I would like those tests being done because every individual is unique. And for example, if I wanted to do a protein C and a protein S, and when you start saying I want protein C, protein S, and they do the entire thrombophilia profile, you see the problem here is the cost factors also. One has to look at the cost factor because once you do a thrombophilia profile, there is such a big hole in the pocket for the patient.
Yes.
You have to be very clear, and sometimes you may have to repeat. And this is where I find that clinical medicine has to take precedence over the biochemistry and the these kind of parameters. And I would be more interested if there is a thrombotic episode, the treatment is going to be very similar. So what is the point in trying to look at all the parameters? So I would like to have a dipsticks method and see that if I am going to be able to treat this patient, then I'd rather spend it on medicine rather than on just investigations.
So ma'am recommends that we should go on clinical parameters
case basis.
more.
Yeah, definitely.
Yes, ma'am. I agree with you. With your experience, no lab matters, no lab tests matter. That is true.
Yes, I wouldn't want to do because many times they'll say whole body scan or they'll say whole body test, etc. Who wants whole body test? I mean, you may do a marketing gimmick, but that may not be required for the patient.
Yes, I agree with you.
Isn't it?
Yes, ma'am, I agree with you.
So
totally
I am
agree
a
with you.
believer is only because I make sure that I want to give what the patient deserves. Rather than say you take one and then you get 3 free, and actually nothing comes free.
Nothing comes free.
They're all
hidden cost. Yes. So if there's nothing else, I'd like to conclude this meeting by first and foremost and maximum thanks to Dr. Kamini for joining us amidst a busy schedule. Thanks to Bedol and Dr. Ramesh, and namaste from KK Med Talks, and hope to see you soon. Good night.
Thanks a lot, ma'am. Thanks a lot.
Thank you.